You all for the Vijaya Diagnostic Center Radiology Education webinar series. Today we are having our presentation on imaging evaluation of the post-operative spine. It is presented by none other than Dr. Ismail from Vijaya Diagnostic Center. We have with us today our chief guest, Dr. Raghav Sunil. Dr. Raghav Sunil is a fellow in endoscopic spinal surgery and is presently a senior consultant orthopedic surgeon at Renova Hospitals, Hyderabad. Dr. Raghav Sunil has done his MS Orthopedic Surgery from Sancheti Institute of Orthopedics and Rehabilitation, Pune, and fellow in endoscopic spine surgery from with the Dr. Satish Chandra Gore from Pune, and again did a fellow in stenoscopic spine surgery from Korea. Has extensive training and experience. Is worked in many places. Is worked in as a consultant orthopedic surgeon at Dr. Mehta Super Specialty Hospital and at Active Spine Care, Jubilee Hills, and Deccan Hospital, Somajiguda, and previously worked as a consultant endoscopic spine surgeon at Abyss Hospitals, Hyderabad. He has excellent academic pursuits with multiple papers and seminars to his credit. There are presentations in multiple international conferences such as SICOT and SIROT and many other conferences. Dr. Raghav Sunil conducts multiple pain procedures like trigger point injections, lumbar nerve root blocks, lumbar epidural, and lumbar facet blocks, and endoscopic spinal surgeries, endoscopic lumbar spinal fusions, and open spine fixations, percutaneous spine fixations, and other procedures. Welcome you, Dr. Raghav, for this webinar.
Thank you very much, sir. Thank you for your kind
introduction. To our presenter for today's topic, Dr. Shaik Ismail. Dr. Ismail?
Good evening, sir.
There? Yeah.
Yes, sir. Yes.
Yeah, Dr. Ismail is a very young, dynamic radiologist from Vijaya Diagnostic Center. Presently, he is placed at Mancherial branch. Even though it is a Type 2 city, but Dr. Ismail's qualifications are like he did his MD from Kakatiya Medical College, and he has done his European diplomate in radiology, and he is a diplomate of Indian College of Radiology, and he is worked in Sri Satya Sai Institute of Higher Medical Sciences, Bangalore, and presented multiple educational exhibits at RSNA 2022. That is very prestigious thing, and he has educational exhibits at as a secondary author at RSNA 2022 related to the spinal post-operative spinal imaging, also radiological evaluation of post-operative spinal complications. That is one of his educational exhibits at RSNA 2022. And he is co-authored as a first author in multiple textbook chapters. There are 3 book chapters, that is CT versus MRI in congenital heart disease, imaging anatomy of upper and lower limb radiological arterial anatomies, and he has multiple papers to his credit. With this short introduction, I just want to open up the discussion with Dr. Raghav first. Raghav, what expectations from us, after surgery or after any procedures, initially how you want to plan, if patient again comes with pain and some kind of, want to see it, what do you expect and what do us to do it?
Sir, when we were in training, the
yeah, you're mute, Raghav. We were not able to hear you.
Can you hear me now?
Oh, I think.
Can you hear me, sir?
You're able to hear?
I am not on mute.
Yes, sir, we are able to hear you, sir.
Can you hear me, sir?
I think there is some technical glitch probably. I'm not able to hear really.
Dr. Ismail is able to hear
Ismail,
me.
are you able to hear?
Yes, sir, I'm able to hear, sir.
So you are able to hear, huh? I think some problem with my mic, I think.
So 1 second, I think.
Can I join from YouTube? With mic. Mic. But the Raghav's voice is not here.
Hello.
Ismail sir को भी नहीं आ रही
No, Ismail sir is not saying. Dr. Ismail, are you able to hear when Raghav
Are you able
is?
to hear me?
Yes, sir, able to hear, sir.
You are not able to hear. My problem only, I think something. Yeah. No, voice are there. I'm not able to hear from here. Okay, I'll hear from this side. Open this link.
देखिए सर अभी
Hmm.
अभी आ रहा है कुछ
देखिए सर अभी।
कुछ नहीं कुछ
Yeah, Raghu, we can start it again. Yeah. So what are the things you expect from the radiologist?
So when we were training, we were always taught not to do a post-op MRI after you do a discectomy because there were a lot of these doubtful shadows which it is very difficult to justify doing a regular post-op MRI unless there is some sort of a complication. But as I progressed and started doing endoscopic, we were started with transforaminal spine surgeries. There also we were not very comfortable doing post-op MRIs because the post-op changes were very minimal. But the last few years, we kind of try to do post-op MRIs regularly for two reasons. One is to document the surgery. In the sense, when we do a discectomy, we would have removed a piece, and recurrences are common, can happen if the patient is not taking care of themselves. So, if we do a post-op MRI immediately after surgery, we will have documented our surgery, and we know for sure that if any complication happens, it is not our responsibility. That is one of the reasons we do. Second reason we do an MRI now is to learn exactly what we have done and if there is any room for improvement. Because when we are doing an endoscopic spine surgery, say, we sometimes think that we have decompressed quite a bit, but when we do an MRI, we realize that we probably have or have not decompressed as much as we wanted or more than what we should have. So it will help us fine tune the surgery and help us keep our learning going. And I do not advise people to do MRIs post-op continuously for all patients, but definitely if there is some doubt with the surgery, or if you want to document your surgery, or if there is any complication like any post-op hematoma or any few days post-op, if you want to see there is any if you are suspecting an infection or any other complication, you should definitely do an MRI. And I also do believe that we should communicate with this radiologist about the surgery we have done, so that they know what to look for and give us a heads up regarding any untoward findings. Hello. Hello. Hello.
Yeah, thank you, Dr. Raghav, for the excellent inputs about the clinical things. And apart from that, I think the chronic complications like anything like arachnoiditis and
Yeah.
recurrent like disc herniations or these things.
So we do get another bunch of patients who come little later of cases we have done or cases somebody else has done. They come to us for a second opinion, which is a few months down the line. So there we would be looking at chronic arachnoiditis, any residual compressions or any new compressions which has come as compared to the pre-op or immediate post-op MRI, or any other new symptoms which has arisen, so that what is a post-op imaging will help us identify the problem clearly, especially misdiagnoses. People when there is a double crush syndrome, like we have a thoracic disc and or a thoracic compression and lumbar compression. Some of these centers don't give a full screening of the spine, unfortunately. So we would not have an inkling about the other compressions higher up. The patient would have been operated for, say, a lumbar disc, but he might have a thoracic compression or a cervical compression, which would have been missed. So to identify various reasons why the patient would come back to you if the symptom has not gone away or the symptom has worsened or he has got a new symptom. So we need to do the investigations to see why any of these three possibilities has happened. Hello.
Yeah, thank you, Raghav. Yeah, we'll move on to the presentation by Dr. Ismail, and after that, again, we will discuss about the things. Yeah, over to Dr. Ismail for your presentation.
Yes, sir. Respected today's chief guest, Dr. Raghav Sunil sir, Director Krishna Mohan sir, seniors and colleagues. Today's topic of discussion is imaging the post-operative spine. So there are various modalities of imaging, and the X-ray and CT. They are usually CT is usually X-ray is usually done as a part of follow-up, especially in cases of instrumentation, and in order to look for any instrumentation failure or instrument-related complications. And the use of CT is also similar to X-ray, mainly to look for any instrument-related complications, instrument fracture or malposition, and also to look for osseous fusion, especially in cases of stabilization and fusion procedures. The role of MRI is usually is usually done for early complications, early dreaded complications, and long-term complications. Early dreaded complications include a post-operative spondylodiscitis, or a post-operative hematoma, or infected post-operative collection, or vascular injuries and spinal cord infarcts. And in long-term cases with the patient presenting with a new complaint or increased paresthesias or increased low backache, so to look for the presence of recurrent disc bulge, or for the presence of adjacent segment degeneration, or for epidural fibrosis, or arachnoiditis, as sir has mentioned before. So a brief introduction about the surgical procedures. The surgical procedures include decompressive and stabilization and fusion procedures. So decompressive procedures will, as the name indicates, laminotomy, laminectomy, and laminectomy with facetectomy. Ideally, laminectomy and facetectomy are a part of conventional surgical procedures and are not frequently used now. The idea is to preserve as much as anatomy as possible, especially the posterior ligaments and the facet joints, and reduce the soft tissue paraspinal dissection as less as possible. So the aim is to preserve the facet joint as much as possible, mainly to prevent instability and iatrogenic spondylolisthesis. And in stabilization and fusion procedures, the main aim is to improve alignment, reduce abnormal motion, and help with the final goal of bony osseous fusion. So this stabilization or fusion procedure is usually done with rods, plates, and screws with interbody disc spacers, interbody disc cages, or in cases of vertebral body disease, tumors, or infection, when corpectomy or resection has been done with bony grafts. So the rod construct allows the surgeon for a short segment or a long segment multi-level vertebral body manipulation and fusion, and the screw helps in fixation. So one of the most common one of the most common spine radiograph which we see in everyday practice is post instrumentation. So ideally to look for the position of transpedicular screw is that the screw should be located ideally between the pedicle. It should not breach the medial pedicle cortex and extending into the spinal canal or into the neural foramen. And with fusion procedures with increased use of interbody disc spacers, and these disc spacers are usually made of titanium or teak or carbon fiber, and the disc spacers are are often filled with bone graft material in order to increase the chances of arthrodesis. So and these interbody disc spacers have a radio opaque marker at the posterior margin, and the ideal position when we are evaluating everyday radiograph is that the posterior marker should be located 2 mm anterior to the posterior cortex of the vertebra. And I'll show you a few examples in the following slides regarding the instrumentation failure and instrument related complications. And there are various basic approaches for spinal surgery, and the cervical spine is usually approached anteriorly and posteriorly. Anteriorly, the commonest post-op X-ray which we see in everyday practice is following ACDF. So ACDF is usually done with anteromedial or anterolateral aspect with respect to carotid sheath, or through the retropharyngeal approach. And the main aim is decompression and discectomy and removal of the posterior osteophytes with fusion of the vertebral body segments. And the posterior cervical fixation is usually done in cases of OPLL, or where there is long segment canal stenosis or multi-level degenerative disc disease, where the main aim is canal decompression. And in thoracic spine, the most common approach is posterior approach, and anterior or the lateral approach is rarely used. Whereas in lumbar spine, the approach is named according the procedure is named according to the approach. So if the approach is from the anterior aspect or through retroperitoneal dissection from extending from anterior abdominal wall, so it is called anterior lumbar interbody fusion, or through lateral, where lateral or extreme lumbar interbody fusion, where the approach is through the psoas muscles through retroperitoneum. And as the name indicates, posteriorly, where the approach is through the posterior paraspinal tissue in cases of posterior lumbar interbody fusion. And the variant of posterior lumbar interbody fusion is the transforaminal interbody fusion, where there is an oblique approach from the posterolateral oblique approach with facetectomy. So coming to a brief introduction regarding the interbody fusion. So main aim of the surgery is to increase the intervertebral body height, reduced abnormal mobility, mainly at the level of neural foramen or in between the intervertebral bodies. So in anterior lumbar interbody fusion, it is usually done through anterior 4 to 6 inch incision, and the surgeon dissects through the abdomen or through the retroperitoneum, and major vessels are identified, and then anterior longitudinal ligament is removed, and then annulus fibrosis is removed. And once annulus fibrosis is removed, then discectomy is done with the placement of interbody interbody disc cage or interbody disc spacer along with bone graft with fixation anterior and posterior fixation. And similarly, in cases of posterior interbody fusion, the main aim of the surgeon is to increase the disc height, prevent abnormal mobility between the disease segments, and to achieve osseous fusion in order to maintain the stability. So here again the approach is through the posterior paraspinal tissues, and once initially the initial step is posterior fixation. After posterior fixation is done, then this helps in expanding or increasing the intervertebral disc space. Then laminotomy or laminectomy is done, and then the thecal sac and narrow root can be displaced, and then discectomy or interbody disc spacer along with bone graft is placed, and then again finally posterior fixation is done in order to help in bony fusion and also maintain stability. And transforaminal lumbar interbody fusion, it is like a variant for posterior interbody fusion, where there is a posterolateral approach with facetectomy, and the steps are similar. When where the part of annulus is removed, interbody disc spacer is placed, and then again posterior fixation is done. This diagram shows the various modes of approach for the lumbar spine, from oblique, lateral, extreme lateral, and this extraforaminal lumbar interbody fusion. This is commonly used for microscopic surgeries, and posterior lumbar interbody fusion. And there is a recent trend with increased intraoperative monitoring, and so there is a increased trend towards minimally invasive surgery and predominantly endoscopic and microscopic tubular surgeries. The main aim is to reduce the soft tissue dissection as much as possible, and to preserve the posterior elements as much as possible. So this, because the resection or the soft tissue or the bony manipulation is very minimal in cases of this endoscopic or microscopic tubular surgeries, this leads to a challenge in recognition of the post-surgical changes, especially if there is a longer post-operative period. These changes are very subtle and cannot be appreciated. That's what Sir was emphasizing before. First, to confirm the level and to have a documentation. And this is a brief diagram how for approach of an endoscopic or a microscopic surgery is done. So initially a guide wire is passed, then a dilator is passed. After the dilator, a portal tube, and through the portal tube, the endoscopic or microsurgical tools, which can be light source and irrigation channel lens, etc. And once this is passed, the tube has a beveled edge. This beveled edge helps in displacing the narrow roots, and then a foraminotomy can be done. Then a laminotomy can be done, and with this laminotomy, then the nerve roots can be displaced, and then the surgeon can go for a discectomy, or through the foraminotomy. This after the foraminotomy, displacing the nerve, if there is a paracentral disc extrusion or a disc herniation, then that could be extruded. So there is a recent trend towards minimally invasive surgeries as much. So the aim is to prevent soft tissue dissection and prevent posterior elements preserve posterior elements as much as possible. Here are a few examples. So most of these are the cases which I have seen during my residency and my practice. So this patient came for a routine post-op X-ray, and we see the right transpedicular screw is extending into the spinal canal. So the patient underwent CT, and the CT is confirming the same. So ideally, the position should be within the pedicle, and it should not breach the cortex of the pedicle or extending into the neural foramen. And this is also a posterior lumbar fixation case. So here we can see that right S1 transpedicular screw is fractured. So in cases of multi-level fixation, so if there is implant failure or implant fracture at one level, it is better to inform to the surgeon, because most of the times if there are multiple fixations, so failure at one point will not have much impact, and it will not be a case for re-exploration. So as the patient was asymptomatic, the surgeon just continued wait and watch management. And this case demonstrates the optimal placement for an interbody disc spacer. So a case of grade 1 retrolisthesis where interbody disc cage was placed 6 months post-op CT. There was some listhesis, but the cage was appropriately positioned. There is no there is no posterior migration of the intervertebral disc cage. So in the 12 months post-op CT, when the patient was complaining of persistent to increased symptoms towards the right limb, so the surgeon again referred for a 12-month post-op CT, and in the 12-month post-op CT, we can see that the disc there is posterior migration of the the intervertebral disc spacer into the spinal canal. So the rule is to the appropriate positioning is that the device should be located always 2 mm anterior to the posterior edge of the vertebral body. And coming to brief introduction along the cervical instrumentation. So with the increased use of neuro navigation, there is increased use of transpedicular fixation. So ideally transpedicular screw fixation is done at C2 and C7 levels, because C3 to C6 have a small pedicle. So usually transpedicular screw is placed at C2 and C7 level, and it is directed superiorly, anteriorly, and medially. Whereas a lateral mass screw will be directed will be directed superiorly and laterally. So this orientation usually helps in especially when reporting a post-operative CT. Sometimes the patient does not bring any operative notes. So just to get a brief idea of the fixation that is being done and to look for complication. So and also the commonest post-op X-rays which we see for ACDF. So ACDF, the cervical plate should be flushed anterior to flushed tightly to the vertebral bodies, and the screw fixation should go from anterior vertebral body up to the posterior cortex. It should not breach the posterior cortex, and also there should be at least 5 mm gap between the superior and inferior margin of the cervical plate to adjacent vertebral bodies in order to prevent heterotopic ossification. So these are the like at least the radiological findings which we should keep in mind while looking at a post-operative X-ray or CT. These cases, these both X-rays show ACDF with a disc prosthesis and disc cage and interbody disc spacer with fusion. And this CT shows a normal lateral mass screw which is directed superiorly, anteriorly, and laterally. So this patient came for a routine follow-up 3 months after surgery. On X-ray was showing there is complete loosening and posterior migration of C2 lateral mass screw, and C3 to C5 lateral mass screws are loose, and there is partial posterior migration of the lateral mass screw. And the surgeon was informed accordingly. The patient underwent re-exploration, and the lateral mass screws were removed, and the occipitocervical fusion with translaminar screw was put. And another important imaging modality in the post-operative imaging, especially for instrumentation and for assessing bony fusion, is CT. So CT and X-ray. So whenever we are assessing for radiographic fusion, usually radiographic fusion osseous fusion takes time. It takes time up till 2 years. So in order to call for non-union, so like the duration should be always kept in mind, because we can see in this case for follow-up X-ray after 9 months after surgery, there is a lucency along the interbody fusion. So this lucency represents fibrous union or pseudoarthrosis, and the following CT after 1 year, where there is complete fusion of the vertebral bodies. So whenever we are interpreting a radiograph or a CT that is specifically requested for the assessment of the union, the duration should be always kept in mind, and always. The main rule which we should always like see when we are interpreting is there should not be any vacuum phenomena or any lucency between the vertebral bodies or through the disc space or through the disc space. And also there should be fusion from the disc vertebral end plate interface without any lucency. And if there is presence of lucent area with some sclerosis or without some sclerosis, without any osseous fusion between the vertebral bodies, It indicates micromotion and suggests fibrous union or pseudoarthrosis. And before going for spondylodiscitis, it is always to keep in mind that there is a considerable overlap between early postoperative findings and postoperative MR imaging within the first 6 weeks is very challenging to interpret. And this post-discectomy changes where there is manipulation of anterior epidural space and annulus that results in anterior epidural space edema, and that mimics recurrent disc bulge. And these changes persist up to 2 to 6 months after surgery. So these points should be kept in mind before we are calling recurrent disc bulge, especially in following 2 to 6 months after surgery. And also, if we are seeing a disc herniation where the signal is similar to that of a parent disc, and also the location is on the contralateral side, when we're confident that it is a recurrent disc herniation, or even on the ipsilateral side, it might not be always symptomatic, or so it's better to talk to surgeon regarding the significance. So the idea is that these recurrent disc herniation, sometimes they reduce, they regress spontaneously because of phagocytosis and dehydration. So it is always emphasized to talk to the surgeon regarding the significance. And also nerve root enhancement because of the breakdown of blood nerve barrier, because of due to surgical manipulation or due to disc compression, especially on the ipsilateral side, can be seen up till 6 months following surgery. So nerve root enhancement up to 6 months after surgery is not always the cause of patient's pain. So nerve enhancement which is persisting after 6 weeks has a high correlation with persistent or recurrent pain. And one of the most dreaded complication and usually common indication for MRI spondylodiscitis, there is considerable overlap with post-surgical changes with marrow edema within the end plates. So the important imaging finding which we need to look for is marrow infiltration, which is showing hypointense signal with loss of end plate contour and hyperintense signal on T2, and presence of enhancing soft tissue mass in epidural or prevertebral space. And because of early post-surgical changes, they closely mimic. It is very difficult to diagnose early infection because without any associated soft tissue component or collection. So in that cases, it is advisable to go for a nuclear scan or to go for a image guided biopsy. And image guided biopsy should be the image guided biopsy. The subchondral bone always should be sampled because the site of infection, even though it is from direct contamination or through hematogenous spread, is starts at the level of subchondral bone, and from subchondral bone the infection spreads into the adjacent disc space. So whenever we are going for a image guided biopsy, the subchondral bone should always be sampled. If it is not sampled, and then we get a negative biopsy. And other causes include incorrect sampling site. So MRI helps in that, in order to select the sampling site, and also the lavage aspiration without any subchondral bone fragment, and concurrent antibiotic therapy before image guided biopsy. This is an example showing postoperative spondylodiscitis, a 52-year-old male, persistent low back ache with a lab picture showing leukocytosis. There are end plate erosions with end plate enhancement and a thick wall enhancing posterior collection that is extending up to the spine, soft tissues, with associated enhancing prevertebral and epidural soft tissue. This is highly characteristic for spondylodiscitis, like as I've mentioned before, like MRI helps in many cases, even though it is a very rare complication, because the incidence is between 0.2 to 2.75%. And this is another case showing similar findings where there is end plate erosions with similar clinical picture, persistent low back ache, and the MRI showing end plate erosions with enhancement and epidural soft tissue. So this is also a case of post-operative spondylodiscitis. And another common complication which we see in the immediate post-operative period is post-operative fluid collection, and they vary from hematoma, seroma, pseudomeningocele, and abscess. Hematoma and abscess could be intraspinal and paraspinal, and seroma or pseudomeningocele are usually paraspinal. So seroma is like a lymphatic fluid collection, cannot have a fibrous capsule, and the indication is whenever there are larger seromas, or when the patient is symptomatic, and if there is a suspicion of secondary infection, a percutaneous or surgical drainage is done. And in the case of hematoma, the imaging is pretty much characteristic, and it is usual, and MRI is usually obtained whenever there is intraoperative vascular injury, or whenever there is persistent or increasing neurological deficit post surgery. So one of the commonest indication is to look for any significant post-operative spine hematoma, and the CT and MRI, they show classic characteristic appearance of aging blood on varying signal sequences. And in management in asymptomatic patient is observation and imaging surveillance. And in cases of epidural hematoma, there is need for a surgical consultation for evacuation. And if it is a paraspinal hematoma, then image guided or a surgical drainage can be done. And another common collection which we see is a pseudomeningocele, and pseudomeningocele is due to durotomy, and there is a large fluid collection that is present in the posterior paraspinal soft tissues, and it extending up to the dural thecal sac. So it is not always possible to see the communication with thecal sac. So in some cases, cis or a fiesta heavy T2 weighted thin sequences are performed, and also sometimes CSF flow artifact can be seen. So most of the time, the imaging finding is similar to that of the fluid signal, and if there is some associated hemorrhage, there could be some debris fluid level, and some heterogeneous signal, and usually it shows peripheral enhancement. And if there is a suspicion of secondary infection, there is thick ring like peripheral enhancement, and also if there is associated CSF hypotension due to CSF leak, then we will see smooth dural enhancement on postoperative MR. So if the patient is symptomatic, irrespective of the size of the collection, epidural blood patch or a drainage catheter or surgical repair of the durotomy is done. So if the patient is symptomatic with a CSF leak, then that requires surgical re-exploration for the repair of durotomy. And if there is suspected infection, then the patient can go for an image guided or a image guided percutaneous or a surgical drainage. And another complication, rare complication, is postoperative abscess. The imaging findings are similar to that of spondylodiscitis, thick walled enhancement with diffusion restriction, and the management is image guided aspiration. And like before the initiation of antibiotic therapy, and if there is epidural extension, then surgical drainage and exploration is done. And in patients with spinal instrumentation, there is indication for revision of instrumentation. And this is a case showing postoperative pseudomeningocele. So the patient underwent discectomy and laminectomy, and has a history of serosanguinous discharge with a swelling after 3 weeks post surgery. So T1 hypointense, T2 hyperintense collection with a small thin rim of enhancement that is extending up to the dural sac and anteriorly, and up to posterior paraspinal soft tissues posteriorly. So this is with a CSF flow artifact. So this is pretty much characteristic for a pseudomeningocele. And this is also a similar example. This is a case of CIDP where the narrow roots are thickened. The patient presented with progressive foot drop and backache. So the previous surgical details were not known, but when MRI was performed, there was a oblong-shaped fluid collection at the level, oblong-shaped fluid collection noted at the level of laminectomy site, and there is herniation of thickened narrow roots into the into the fluid collection, which is consistent with a pseudomeningocele. And this case shows a hematoma that is extending from D10 to D12 level, that is resulting in cord compression, where there is which was the indication because of the increased back pain and neurological deficit in the post-operative period. And one of the common indication is especially when the technically surgery was a success and the patient was complaining of persistent pain, or in the post-operative period, we see this surgical changes and the significance is not known, because is usually the recurrent disc herniation or peridural fibrosis. So it is like so the peridural fibrosis can be seen up till 6 months, because it is like normal physiological scar tissue that is being formed, and it usually resolves, or it regresses after 6 months. And because it is important to differentiate between peridural fibrosis and recurrent disc herniation, because recurrent disc herniation, the patient benefits from re-exploration and discectomy, whereas peridural fibrosis usually does not have benefit. And also the imaging findings are pretty much characteristic, where peridural fibrosis will show a persistently hypointense signal and uniform early enhancement on post-contrast studies, whereas recurrent disc herniation will show the signal that is similar to that of the parent disc, that is isointense on T1 and iso to hyperintense on T2, and usually does not show any enhancement. And sometimes peripheral ring-like enhancement can be observed because of the granulation tissue and adjacent dilated epidural plexus. And it is important to remember that the disc herniation and recurrent disc herniation and epidural fibrosis are not always pathological in all the cases, and so this can regress, and the scar can also regress, and the deformity of the dural sac can regress. And this peridural fibrosis causes adherence of the neural elements to the adjacent structure, so which results in compression from adjacent osteophytes or from adjacent discs. So that results in nerve irritation and causes recurrent or persistent pain. So this is a 45-year-old female who underwent laminotomy and now complains of progressive backache. So there is a markedly T2 hypointense epidural soft tissue thickening that is displacing the thecal sac towards the contralateral side with the with concentric narrowing of the thecal sac. And on CT, there are faint areas of calcification noted at the site of epidural soft tissue thickening. So this is consistent with epidural fibrosis. And these images show the preoperative disc show. This preoperative MRI shows left paracentral disc bulge that is causing lateral recess narrowing and compression on the traversing narrow root, and postoperative thrombin surgical packing. So that gives this characteristic speckled appearance, and this hypointense appearance is also seen in hemocele placement or surgical placement following discectomy, and which we see adjacent to the end plate, especially in cases of microscopic discectomies. And we tend to think it as recurrent disc bulge, but in surgical packing, it shows persistently hypointense signal on T1 and T2, and there is ipsilateral narrow root enhancement, and this is due to disc bulge. And in the 6 weeks following the post-operative 6 weeks following the surgery, the patient was persistently complaining symptoms. And this follow-up MRI, again, it shows a subarticular disc protrusion that is causing lateral disease narrowing and compression on the traversing narrow roots with characteristic ring-like enhancement. And this is consistent with recurrent disc herniation. Another complication which results in persistent non-specific or persistent symptoms following a technically successful surgery is arachnoiditis. It could be of 3 types, where there will be clumping and thickened cord-like appearance of narrow roots, where there will be adhesion between the narrow roots and the thecal sac, and where there will be peripheralization of the narrow roots with the empty sac appearance. And sometimes there will be soft tissue thickening and calcification noted within the spinal canal. And the cause of arachnoiditis is not clearly known. It could be secondary to surgical manipulation or postoperative infection, or secondary to intrathecal blood during surgery, or because or due to administration of intrathecal anesthetic agents or anti-inflammatory agents. And recurrent disc herniation, peridural fibrosis, and arachnoiditis are like important causes for persistent pain, and after a technically successful surgery, especially when like a failed back failed back surgical syndrome is considered. Uh, Thank you, one and all, for your time.
Yeah, thank you, Dr. Ismail. Sorry for my technical glitch. Actually, I was not able to hear, so I logged into mobile. So, sorry for that. So excellent, a very informative presentation, Dr. Ismail. So a lot of things you told us, like so much information. So, Dr. Raghav, what is your take on it? Like anything for the discussion?
So, like you said, a very comprehensive presentation by Dr. Ismail. Congratulations. So, what would you tell the clinician? So, if I have a post-operative case where I have to routinely do a scan to understand the extent of my surgery and the decompression, say in a routine decompression for either for stenosis or for discectomy without instrumentation, what would your advice be? Should I do a MRI or should I do a CT scan with or without contrast?
Sir, if the patient is showing improvement of symptoms, then it's not required, sir.
Okay.
Post-operative MRI, like, but when you said this endoscopic surgery, it requires like a lot of surgical skill, and the area that is being manipulated is very less. So I think,
Correct.
as you said, for legal purposes, it is better to document and keep, sir, because long term these changes are very subtle and cannot be appreciated. And the question comes whether the surgery is done, because the incision is also 1 inch incision.
1 centimeter incision
Yeah,
or
one
less.
centimeter. Yes, sir.
So, when we do a discectomy or a stenosis surgery, there is a significant change even on the MRI. Just that, for some reason, when the radiologist reports, probably I've realized that when the sections are taken, if the technician is not taking the sections of the axials at the correct angles and the correct areas, also that will the post-op images sometimes don't look as impressive as intra-op videos which we take. And the reporting also comes in like the persistent stenosis. Maybe the radiologist should look at the pre-op image and the post-op image for post-operative cases and give a comparative report key. As compared to the previous image, these are the changes which are there and these are the persisting changes. That would be a better way of reporting, is my opinion.
Yes, sir.
One point I want to add is with the post instrumentation spine, 1.5 Tesla is better than 3 Tesla always. 1.5 Tesla MRI will show the spinal cord and other details more clearer, because the artifacts, those susceptibility artifacts related to the metal, is much lesser in 1.5 Tesla compared to 3 Tesla MRI. So I have found so much differences. I have done in both the things, both the machines. And 3 Tesla, I couldn't see anything within the spinal canal. When I shifted to 1.5 and did it, I'm able to really give a lot of information to the referring doctor. So 1.5 is always better in post-operative whenever there is any metal is placed, like instrumentation is done in that area. So that's what is one.
That's very useful information.
Yeah, that's. And one more thing
And
about
now cervical spine in endoscopy. In cervical spine also, now in endoscopy we are doing a lot of foraminotomies posteriorly when there is a lateral disc, or if there is a foraminal stenosis, which is a common finding in cervical spine. So we do a lot of endoscopic foraminotomies for posteriorly. Sometimes we can do multiple levels from a single incision. I believe a surgeon's responsibility would be to communicate with the radiologist and discuss what he has done, so that the radiologist who is reporting a post-operative MRI, at least in the immediate post-operative stage, should be able to identify what is done and assess, then give his findings on that. Otherwise, it's like shooting in the dark. You are kind of given an open I mean, unfortunately, a lot of clinicians hardly write any history or anything before they refer a case to a radiologist. Radiologist is left to give a diagnosis based on the images only, and not on the clinical findings or clinical history.
That way it is really difficult. We have to really understand how many
Right.
days after surgery is done.
I understand and appreciate that.
All these things are very, very important. As Dr. Ismail rightly pointed out, that nerve root enhancement is so common after the post-operative period till almost 6 weeks or 6 months, till 6 months, that nerve root enhancement itself. Once we see that nerve root enhancement, we think that still there is a compression, lot of compression, and those signals are seen. But it is the other way around. Like it is just because of, that will not disappear till 6 months almost. The nerve root enhancement, which was due to a compression or post-operative change. So that information is very, very important.
And I have also seen in endoscopic decompression discectomy, sir, the posterior annulus sometimes still keeps elevated. Even after we remove the disc material, the annulus is still elevated. It will on the MRI it will show as a compression in the immediate post-op days. And few months down the line, if we for whatever reason repeat an MRI, quite a lot of times the compression reduce, the posterior annulus would have gone down and the compression would look relieved on the MRI. This is one of the things I have observed in follow-up MRIs for whatever reason.
Even I think post-operative spinal changes, that vertebral body changes, end plate signal changes, always mimic like a spondylodiscitis or infection. But they are just post-hysterectomy. Some changes are definitely seen. Some changes in the end plates are really routine. So those could be just post-operative changes rather than spondylodiscitis. That information also very, very important when we image the post-operative spines.
Right.
Yeah. Ismail, anything more than presentation still? Yeah, thank you, Dr. Raghav, Sunil, Dr. Ismail, for an excellent, the discussion and the presentation. Thank you so much. I think we crossed almost 40-50 minutes now. So,
thank you, sir. Thank you, Dr. Ismail.
Thank you, sir. Thank you, sir. Thanks a lot.
Thank you.
We'll end the presentation.